perhaps more on that to come. So what is a critical sample? Typically, you want a glucose confirmed in the lab. You want ketones, insulin, growth hormone, and cortisol. Those are the 5 ones that I think are core. Depending on where you work and what you think your likelihood is of having inborn errors of metabolism, you may want as well a blood gas, to look at lactate levels or bicarbonate, looking for metabolic acidosis. Free fatty acids would assist you with looking for fatty acid oxidation defects involving the liver, as would carnitine. But again, if you happen to work in a place where you see one of these every 10 years, you're probably not going to send this on every patient. So I told you I'd mention our local Manitoba experience, and so we'll begin by telling the story of diazoxide, and I'll be interested to find out after in the discussion period if others have used diazoxide and if they've had similar experiences to us. But diazoxide is a medication that works very well to treat hypoglycemia. In particular, it's useful when you have high insulin levels, and we'll talk about why in a minute. But as we started to use more diazoxide for this persistent hypoglycemia, so not the transitional, but certainly babies who by a week of age or longer were still hypoglycemic, we began to institute a policy of involving endocrinology, and it made sense because these infants were often on these medications for quite some time, and if they were going home, they would not be followed up by a neonatologist who works in the hospital, but rather by endocrinology. So we worked collaboratively. That was a very sweet part of the experience. We worked collaboratively between neonatology and endocrinology to find a way to adopt the guidelines. But I can tell you, and you might even be expecting, there was a lot of resistance by people who were concerned that we would begin to see copious numbers of healthy babies coming in, for workups of hypoglycemia, who perhaps had transitional hypoglycemia. And then there were questions about separating mothers and babies, and we certainly wanted to avoid that. We did define and embraced the number, even though they specifically stated that there is not a specific number. We did embrace the number of greater than or equal to 3.3, and we chose 72 hours rather than the 48 hours because, again, we were trying to prevent an influx of babies into our units between 48 to 72 hours who really probably just had transitional hypoglycemia. And given that we had a very large population that we serve who are not from the city of Winnipeg, but would be going up north into rural communities and quite far away, we decided that as a precaution, we would implement the 5-hour fast for infants with persistent causes of hypoglycemia because we wanted to ensure that if a mother or father slept through a feed, we weren't going to have a baby seizing in the home. I have to say, it's always nice to have one's ego stroked, and we certainly received lots of email praise and some phone calls from outside of our institution as word began to spread, certainly to people who had put together and spent time on the PES statement that someone had actually embraced it. But in retrospect, we are beginning to think, and certainly with our experience, believe that therapeutic target may be better than the choice of language. It may have been a better choice of language than normal, and we'll talk about why. So what happened over time? So in our local Manitoba experience, we found that, not surprisingly, since we adopted this in 2015, this policy on diazoxide consults, the number of consults went up by a lot. So that was very good for my endocrine colleagues in terms of the pocketbook, not very good for the amount of time that they have each day. But certainly we worked out a great system for not just following these kids in the hospital, but ensuring safe discharge into the community. And this slide is actually unpublished research by Celia Rod, who is an endocrinologist in our center. And she looked retrospectively to see what impact this had had as we changed our policy. And you can see, not surprisingly, between 2010 and, I'm sorry, that's supposed to be 2012. Between 2010 to 2012, we had 58 consults. And then in the next 3 years, we had, sorry, it is 2015. In that 5-year span, we had 58 consults, with the vast majority of them were actually in the last 3 years. So the consults spiked, but what's interesting, well, a few things that were interesting. Number one, for those of you who, and I presume most of you work in neonatal care or care for newborns, or you wouldn't be tuning in, but normally the females in the newborn period do much better than males, but in this case we had, for reasons that are not really clear, about an 80-20 split in terms of females to males. So females were far more common to present with what was the majority diagnosis in 51 cases of hyperinsulinism. And I don't know that that's been reported before. About half of the infants were treated with diazoxide. The median length of, or the mean, length of treatment was 95 days, so 3 months. So this hyperinsulinism does not go away quickly. Now, I would like to stress, though, these kids did not have, with the exception of one infant that I'm aware of, persistent genetically induced hyperinsulinism. Most of them had transient, but it doesn't go away quickly. But the other thing that's important, and I've highlighted there, is that even though we changed our threshold to be 3.3, the kids that are presenting with true causes of persistent hypoglycemia still are presenting at 2.3 as an average, with a range up to 3.2. So I guess the point here is the kids with serious causes of hypoglycemia will still present with lower sugars. So raising that number, you're not going to 3.3 did not capture more kids who necessarily would have presented, or a lot more kids who would have presented. So what about before and after? So we really don't have a difference in the number of babies being treated, or being presenting, that is, with hyperinsulinism, and that makes sense. We can't change the background incidence. We didn't really change our treatment with diazoxide, although the follow-up improved. And so the question is, are we really just investigating a lot more babies? The further question is, and I think we need to see with time, and hopefully Celia will look into this again, as we see more numbers, will we start to see a difference in detection rates? So are there, in fact, a lot of babies that would present with blood sugars between 2.6 and 3.2 that actually do have these conditions that we previously would have missed? Because again, if these babies presenting with blood sugar, if these babies are not presenting because we're not finding them, because we're sending these kids home with sugars of 2.7, 2.8, 2.9, etc., is that good for them? And I will present to you some evidence that suggests maybe not. So on to the sour. So we've talked a little bit about the sweet, and the sweet was, determining what levels are appropriate, talking about collaboration, getting a little praise from the outside. I certainly considered that sweet, but now we're going to talk about the sour. Now this isn't sour, this is just sort of an overview of some of the approaches that we take here in Winnipeg. And I would say to you that you may in your center take a different approach, and that's absolutely fine, but we certainly here to try to prevent hypoglycemia, encourage skin to skin. We really strongly encourage breastfeeding. And we will increase our volume of fluids when necessary to try to deal with low blood sugars. We do use glucose gel and have for some time. We will offer frequent feeding. Sometimes we do continuous feeding to try to avoid an IV, and sometimes we need an IV. And we do use D10 to D20, and we will use that peripherally. We no longer have to really be concerned about using umbilical venous catheters or central lines above D15, as there was a study that showed that the rate of IV loss was not any different. So those are our initial strategies, but then you get down to the lower level, which is things like octreotide, growth hormone, diazoxide, hydrocortisone, glucagon, and depending on your units, and I'm not here to tell you which one is best, but depending on your unit, you'll have a preference for one or another. So our story of diazoxide, I told you that we instituted a policy. You saw the information. I've talked to you about how it inhibits hyperinsulinism. One of the things that our endocrinologists typically talk about are differentiating kids with clear hyperinsulinism who have very, very high insulin levels of 30 or 50 or 100, which is clearly much higher than the reference range, But there's also those who have inappropriately detectable insulin. So the example there I would give you, and I've shown you there, is if you have no ketones in the blood and you've got an insulin level of 8 and you're hypoglycemic, that for that baby is hypoglycemic, because the endocrine response is that the insulin level should effectively be 0 if the baby's hypoglycemic. So an insulin of 8 is still inappropriate. We know that diazoxide works quickly. If you've ever used it, typically within one dose, you'll start to see the sugar rise. And because I have a very strong interest in reducing pokes, I'm delighted to say that we have seen a significant reduction in pokes from using diazoxide when you stop having to check so frequently. Unfortunately, this was brought to my attention on July 16th, 2015. The FDA in the US put out this warning about diazoxide, and what they warned about was that in all cases, that they warned about pulmonary hypertension. And they said that not only was pulmonary hypertension more common with diazoxide, but that if you stopped it, it went away. They identified 11 cases since 1973. So it's certainly not very common, but the reason that this came to my attention was we were starting to see cases of pulmonary hypertension in these kids. And after a few cases, colleagues of mine decided to look into it with some research. And so what they found was that there were 4 cases who developed pulmonary hypertension. Of the 4 cases, 2 of them were large, LGA, and that was statistically significant. And overall, the kids with pulmonary hypertension tended to be larger overall. So you can see the differences in weight. Interestingly, things like PIH, IUGR, abnormal blood flow patterns, none of that was different. And credit goes to Alla, one of our former fellows, for being the lead on this.